Unlock the future of pathology with Pathology News, your ultimate source for cutting-edge insights, expert analysis, and the latest breakthroughs in digital and computational pathology. Don't just stay informed, stay ahead.
Hello and welcome to Pathology News. Today we're coming to you from the city of Cambridge. We're actually at Saucer Biosciences headquarters here in the UK. And today's conversation is going to cover a slightly different subject that we don't usually detail on Pathology News. Today we're going to be talking about PSA, which is prostate-specific antigen tests. Now, they are widely considered the gold standard for monitoring men with prostate cancer. And as we'll find more about today, many of these men fall into what we call a diagnostic grey zone. And in that area, the GP and the patient don't have a complete idea of what the next steps are. So with that in mind, today we're asking, what could better decision-making look like? And what role could new risk stratification tools play in supporting smarter, more personalised prostate cancer treatment pathways? To explore this in more detail, I'm joined by my two guests today, Dr Asif Naseem, who's a GP based in London, and Dr Beat Rheiner, who is the CEO of Proteomedix, who's going to bring a completely different angle, I believe. Welcome to the podcast.
Thank you, Sid.
Thank you very much.
Lovely to have you here. So as new guests on our podcast, I was hoping you could tell us a little bit about what you do and why you're so passionate about being in this space.
Thanks, Sid. As I said, my name is Asif, and please call me that during the podcast, and thank you for inviting me here. So I'm a private GP based in Liverpool Street in London, Chief Medical Officer there for a clinic called LSDC Healthcare. And I have a particular interest in preventative healthcare, cancer detection and men's health. And as part of that journey, I then was involved with the Graham Fulford Charitable Trust, which is a prostate cancer charity. And for the last 2 years, I've been working with them as a medical advisor, but also supporting men who've had a PSA test and they want to know more about that and help them on their journey.
Yeah, super, thank you. So, exceptionally relevant to today's conversation. And Beat, what about yourself?
Well, I'm actually a pharma professional from my background, so chemist by training.
Yeah.
And I worked all my life in cancer, but on the drug side usually. And there we had, of course, a big touch point with diagnostics. And even the interest of the pharma industry is to come earlier and earlier, because that's really where you can change the lives of the people.
Yeah.
So by identifying prostate cancer as early as possible, you really can make a difference to the population and avoid a lot of deaths.
Yeah, fantastic. And I'd like to talk about that a little bit more in a moment. But for our audience who are vastly interested in digital pathology and AI, which is the focus of our publication, I was hoping we could kind of link today's conversation to that. Asif, could you tell us a little bit about the diagnostic pathway here and what that looks like from a GP's perspective?
Absolutely, yeah. So obviously, when it comes to prostate cancer detection, it is now obviously much more widely publicised, and obviously with the likes of Sir Chris Hoy and His Royal Highness the King having had prostate cancer, it's really brought it to the forefront of a lot of men's mind. So that journey really starts from either a personal understanding, maybe what they've heard on the news, or just an offer or a family member pushing them to go and have a test. And what's being obviously available to pretty much an equity point of view is the PSA test and the prostate cancer screening test. And it's really important that actually a lot of men don't fully understand that it's not a cancer test. It's a protein test that we look at when it's related to prostate disease, but it's not a prostate marker. It's not a prostate cancer marker as such. So they will come along and they will have that blood test, and then that will, for them, they will understand from that either they will meet the threshold for further investigation or they won't. And there are age-related ranges. So the NICE guidelines, who the National Institute of Clinical Excellence in the UK, have obviously set out specific guidelines that if you're above a certain age, if your PSA threshold will be this,
Yeah.
And then therefore you can then go on to have further investigations, or this may be clinically significant.
Yeah.
But those are based around men who have got symptoms. And
Yeah.
that is another reason why men may want to wish to consult their GP and say, okay, well, I have waterwork symptoms, I'm having difficulty passing urine, I'm waking up at night, for example,
okay.
those kinds of classical things. So that might be another entry point into the prostate cancer pathway.
Sure.
Once they get their result, then the GP helps them decide as to where they go next. And if they meet the threshold, they'll be referred to a hospital where they'll have either an MRI scan, conversation with the consultant, obviously, to decide what needs to be done next, and potentially a biopsy to understand if they do have, cancer.
Yeah. Well, thank you for setting the scene for us there. And a Beat question for you then. How important is it to diagnose men early with prostate cancer?
It's hugely important because prostate cancer is something that, in many cases, is not leading to death. Fortunately, because it's the most diagnosed cancer in men. However, in the UK alone, I think around 12,000 people are dying each year from prostate cancer, making it the second most deadly cancer after lung.
Yeah.
So it's a huge issue when you detect cancer early. This data comes from the big screening study with PSA from the ERSPC trial. You can actually reduce the mortality by about 1/3, so 30% or a little bit more. And that's massive already.
Yeah.
But I think we can improve this number drastically in the future as well.
Even further, yeah. And I think that stems back to the core subject of today's conversation, which is really about the reliability of what we call the gold standard, the PSA test at the moment. So I'd like to touch on that. How reliable are PSA tests? Asif, could you talk to that?
Yeah, sure. I'm going to say that probably gold standard is a strong word to use for PSA tests. I think it's the entry point, and I think it's the most robust test that we've had and the most accessible test. I think the gold standard, you probably would, if you're thinking about prostate cancer diagnostic tools, you're probably thinking about MRI plus biopsy. And in terms of being specific for prostate disease, then yes, the PSA is really reliable and is specific for that, but it's not sensitive for cancer, as you know.
Yeah.
And so you'll find that the PSA itself, there is a high risk of false positive. So I believe it's in the region of about 75% of people who have got a raised PSA above the threshold will not have any form of cancer detected. But there is a small chance, 25% chance that they still will have cancer. But also there is a risk of false negative as well, and that's in the region of 1 in 7 or 1 in 8 people would generally tend to have a low PSA, so not meeting the threshold for referral, but actually still have some clinically significant prostate cancer.
Okay.
So in November 2025, the National Screening Committee opened a consultation process. PSA is still now not considered as something that we should be using as a screening tool, even to this day.
Yeah, Beat, I'd love to hear your thoughts on that as well. Why do you think decision making is still unclear after patients receive a PSA test?
Yeah, as I said before, PSA has shown a value in terms of preventing cancer death. So it is still a good tool to try to make this triage. However, PSA has actually two things that are not great. So one thing is, I think PSA really tries to make sure that amongst the positives, there are the people with cancer actually. But what happens is that because PSA is organ specific and not tumor specific, you will have a lot of elevated PSA results based on daily activities like biking or sex the night before, whatever it is. So PSA can be elevated due to very different reasons than cancer. This produces about 70 to 80% so-called false positive results. So you're getting an elevated PSA back and you might be worried, but you would be healthy. And that's a big problem, and that's why PSA is not, at this point of time, not called to be really sufficient for making this triage. The second point, actually, PSA is cancer and the clinically significant cancer within the PSA range is actually distributed frequently also in the lower PSA values. So the most frequent findings are actually between around 1 to 4 PSA.
Yeah.
But what was found is that when you have an elevated PSA, because of the reduced number of people, you have a better chance to find the clinical significant PSA, even though you miss most of them at the end of the day, which is not so commonly known at the moment, but
absolutely.
It's a problem.
Good reason for doing this podcast, I suppose.
Yeah.
Asif, I wanted to come to you next and talk about the symptoms that people express with prostate cancer.
So notoriously, you'll hear obviously is that actually there are no symptoms. A lot of times men will present with, they will not have noticed any problems at all, which is, I think, the scary thing about it, essentially, and which is, I think, really illustrated with Sir Chris Hoy's scenario as well, in the sense that this is not something that will give you bond or symptoms all the time.
Yeah.
But when men do present with prostate disease, they will present with certain urinary habit changes. So they'll be potentially either going more frequently for urination. There might be some dribbling. There might be some stop-starts of feeling like they can't fully empty their bladder. They might be having some pain sometimes.
Yeah.
That's less likely, but they can be potentially there. They could have sometimes blood, particularly in the semen. And sometimes, obviously, they can experience, obviously, waking up at night to pass urine more frequently. And again, that's because during the day, they're not able to empty their bladder fully. So then they're having to wake up through the night to continue to empty their bladder because there is outflow obstruction from the prostate, from an enlarged prostate gland. And so normally you will find that they will generally present with those symptoms. And then very rarely you might get a gentleman presenting who's maybe ignored some subtle signs. But if they do have metastatic prostate cancer, they may present with spinal pain. And obviously that's quite a big red flag.
So there are quite a few symptoms there, but perhaps not obvious for all men.
Yeah, absolutely. Which is what this whole conversation about screening is so important. Is actually, the PSA, as we were saying, was that it's a really important triage tool. So it's the best one we have. I don't classify as obviously gold standard, but it's the best one that we have access to, and it's the one that we're going to keep using. But at the end of the day, we still need to get those men through and actually stratify them and say, okay, look, once you've had a PSA test or once we've identified you as somebody who might have a problem, it's really important that you then go on to have these further investigations, because really a lot of the time the men I'm speaking to will be scared or feeling anxious about the fact that actually they've gone for a test, they have no symptoms whatsoever, but have actually now have received an elevated result. And it's hard to get your head around, right? And if you're saying this, like, I feel completely fine. And actually, if my wife hadn't sent me for the blood test, then I wouldn't have known about this. Or, for example, if I hadn't signed up for this. So it's an interesting area.
Thank you. And to go back to this grey zone then, from my understanding, the grey zone is where you have a level of between 2 and 10. Why is that such a difficult area to manage? Beat, could you talk to that?
Yeah, I think it's just an area where a lot of men are landing with their PSA. And as I said before, it's like 80% might be false positive and they don't have actually any sign of cancer. And that's where I think that's why this range is so important. And the second point was that the clinically significant PSAs are actually frequent in that range. So you will detect a lot of those when you have something to analyze this.
I mean, from my point of view, exactly that grey, and it's not a term that we like to use quite often, but that area between 2 to 10 is essentially where we have the most difficult conversations with men. It's because we can't give them that clarity sometimes and say to them, look, if you've got a bond when your PSA is 50, you are 100% going forward for further investigation tests. So you clearly got on. If it's quite low, so if it's less than 1, then your risk is, all the evidence shows that your risk of developing prostate cancer is quite low. So that area is probably where most men will present, as Beat was saying, but also giving them that reassurance then becomes also the most challenging conversation.
And you mentioned that you prefer not to use the term diagnostic grey zone. Talk us through that.
Yeah, I mean, I suppose it's not so much a grey zone because we know that there is enough information there. We just don't have the triage tools to put people through to further investigations. I think that's probably where, because I think for a grey zone for, I suppose, a layperson, coming to a medical conversation, will think that, okay, well, this is something that we don't really know about. Actually, no, we have a lot of information about, and there is a lot of research. Yeah,
you should call it the decision zone.
Yeah, yeah, absolutely. So it's an area that's actually we've got plenty of evidence, we've got plenty of information. It's just how we proceed is the grey bit, because it's very individualized. And the reason why I say that is because it really is down to that personal. So then it becomes a very individual conversation. Is what are their symptoms, if any? Do they have any family history? Are there some other factors which are playing into this? For example, the other non-cancerous reasons. So the majority will just have a benign enlarged prostate gland, because the bigger the prostate, the more PSA you release. And so, or if you have prostatitis, an infection, for example. So there are so many other reasons, conversations to be having had there. But then how do you proceed with that, and how do you delineate those patients into saying to, look, you need to go along the cancer pathway, and you need to go along for another pathway? Well, there's nothing to be concerned about.
So I'm wondering, I'm assuming there's a large cohort of patients who we don't have a firm diagnosis for, and is that cohort, are they referred down a suboptimal patient pathway?
I think suboptimal is, again, probably not a word I'd use. I'd probably say incomplete, I'd probably say, because the pathways that we have in place in the NHS and in the private sector are what we have access to, and they are picking up cancers and they're detecting patients and they're giving them a really good outcome. So I think what's missing is probably that further information, or that incomplete information of giving that triage. Is that, again, coming back to what I was saying, was that actually we're not able to filter finely enough those patients who have got high risk prostate cancer into the pathways that we do have already. So the MRI scan, the biopsy, the further investigations, to go on to have whether they need surgery, radiotherapy, etc. So all those pathways set up quite nicely. It's actually the funnel that goes into that is too many patients are going in, and there's probably more harm being caused by not risk stratifying those patients more early on. And obviously that puts a drain on resources.
So let's take a typical scenario here. Let's say we have a patient with no clear symptoms and a PSA of 4 to 5. As a GP, what's weighing up in your mind in that situation?
Absolutely, yeah. So, good question. It is quite a common area that we have to deal with, and so obviously it depends on the patient's age. And I'm going to give you the political answer. It all depends on the situation. Obviously, we use the age-adjusted guidelines threshold, but for argument's sake, this gentleman is 50, and their PSA, according to NICE guidelines, should be above 4.5. A lot of the other research, particularly the European research, and obviously a lot of the consultants in the UK still feel like a level cutoff of 3 is much more indicative, or picking up cancers much earlier. So you will also find this friction, or this conversation between the either consultant specialists, but also what the NHS GP can refer through to. So you've already met either the criteria for further referral, or you haven't. And so in that scenario, if your age adjusted PSA level meets the threshold, that makes it easy for the NHS GP to then say, okay, look, the local hospital, we can fill in the criteria, say, look, we've had a PSA result. One barrier would be, or two barriers can be, the fact that if the patient doesn't present with any symptoms, because sometimes that is obviously the important part of the NICE guidelines, but also if, for example, a rectal examination is not performed, or they don't have 2 PSA results, because there are parts of the country in the UK where the criteria is that the GP needs to then perform a second blood test after 6 weeks, a rectal examination and a urine test to confirm there's no evidence of infection. So that would be your pathway going forward, and then obviously that just makes it easy. You pass on the care to the consultant colleagues. I guess where I find the tricky part is that those patients have not been either referred, or they've been left to deal with that PSA result by themselves, or they found themselves in a situation where they've done the test, they've not had a chance to speak to a GP, but they want to get some further clarity or information. And for those patients, we'll lay out, and again in the private sector, we'll have a few more options, like for example, access to reflex testing such as Proclarix, where the patient can get further clarity on whether their PSA or whether their disease process is higher risk for prostate cancer or not.
Yeah, great. And to take a slightly different angle then, a different scenario, what about the situation of a PSA level of 2 to 3?
Well, in that area of 2 to 3, this is the area where usually everything is missed, because the cutoff for PSA values is 3 and above.
Okay, yeah.
US even 4 and above. So that is why it's very important to look also into the 2 and 3s, because in the values between 2 and 3, because the frequency is still very remarkable of the clinical significant cancers there.
Asif, come back to you. As the GP, with you're the decision maker in this situation. How, with the information that you currently have from PSA testing, how confident do you feel in making decisions?
Not very. So even with my particular interest in prostate cancer and obviously PSA, and obviously you develop, and once you're in that space and you're in that field and you're kind of speaking to a lot of patients and you're seeing the follow-up, then you start to develop obviously that tacit knowledge that you would develop through treating these patients and managing them. Even then, there are cases that will catch you out. So there will be those with PSAs, as Beat was referring to, that would be, okay, there are 2, but they've got actually clinically significant prostate cancer. Now, I'll have another man who come to me with a PSA of 2 and say, should I do anything? Now I'm kind of thinking, okay, well, actually, I've just seen 2 cases of a situation where the PSAs, but the statistics and all the evidence will tell you, well, actually, it's a very low chance of that potentially being a risk. So I'm usually then obviously looking, I'm doing the risk stratification internally. So I'm speaking to them, I'm finding out about the history, the family history, genetics, all those kinds of things to help me risk stratify. And in the NHS, the PSA result is reported as a total PSA. But in private labs, you will get the PSA ratio. And that is just it's not the most sensitive, but it is another layer of evidence that we can use to try and help us with our decision-making process. And I can give the patient then further information, say, look, based on what you've told me, your age, your symptoms or lack of symptoms, your family history, etc. Then I can say, okay, well, based on my experience, I think this is what you should do. But it's not it doesn't give me a huge amount of confidence.
Yeah, absolutely. And I'm wondering if that lack of confidence transfers to the patient as well. As a GP, do you ever pick up on that? How does the patient feel, being in that grey zone?
Absolutely, yeah. So, and this is the challenge, right? So as an NHS GP, you will only have 10 minutes. Now, and typically this conversation will come out as they're leaving after they've just spoken to say, oh, by the way, my wife said I should get a PSA test. Can you just do the test for me? Now you've got 30 seconds to make a decision as to whether you want to fully consent this patient to explain all the risk of false positive, false negative. For them, it feels like a simple tick box and do the blood test, you get a yes or no. So I think for me, it really is, we have to set the scene in these triage scenarios, is that if the patient doesn't get the right information from the beginning, then they do lose that confidence. So then you can see it quite quickly when they come to me with a result and they're like, I had no idea that I was going to get a positive result. Now, what does this mean? I'm like, well, actually, the test isn't that accurate. There's a huge risk, there's a huge chance of it being false positive, false negative. So you will have all of these scenarios, and then you can just see as the conversation goes on, they start to lose that a little bit, like, okay, well, why did I do this test in the first place? Why am I here? And it's actually, okay, so it could mean nothing then. I'm like, yeah, but it could mean something. So we don't know. And yes, and that kind of, you can imagine, a doctor is sitting there having that conversation with you saying, well, I can't really tell you for sure. Then not. And patients are very understanding. They understand that obviously tests have their limitations. But for simply speaking, you're quite anxious already. You've already been sat on this result for maybe a week or 2 weeks. You've had sleepless nights thinking you've got a cancer sitting in your prostate which is growing, and then you've got a doctor then you finally get to speak to then who then says, we're not sure.
Yeah.
So yeah, it is a challenge.
Yeah, no, it's really difficult for the patient and you as a GP as well. You know, I think as a GP who's often making that clinical decision, you know, you want to be in a position where you know factually that what you're looking at is what you think it is, if you know what I mean.
You know, we're trained to deal with uncertainty, but we don't have access to all the information.